Okay, welcome back. This is the second half of the chapter on the human reproductive system, and we're examining the female reproductive system. We've got here a superior view of the female reproductive system showing you the uterus, the fallopian tubes, the ovaries, and the associated ligaments that maintain the position of this organ system inside the abdominal pelvic cavity. If we look at an anterior view, we note that the ovaries are the paired female gonads found on the lateral walls of the pelvic cavity that make ova. These are the eggs, the female gametes. They secrete hormones such as estradiol, estrone, estriol, as well as progesterone, inhibin, and relaxin. Anatomical features of each ovary include the cortex, a superficial region where oogenesis occurs within follicles, which are found in the cortex of the ovary. The ovarian medulla is the inner region where the blood vessels, lymphatics, and nerves originate. Each ovary is held in place by three ligaments that provide support. The broad ligament is a large flat ligament that attaches to the ovaries, uterine tubes, and uterus, connecting these structures to the bony pelvis. The ovarian ligament connects the medial surface of the ovary to the uterus, near the attachment of the uterine tube. A suspensory ligament, also known as the infundibulopelvic ligament, connects the lateral surface of the ovary to the pelvic wall, providing support for the ovarian artery and vein. The uterine tubes or fallopian tubes, also known as the oviducts, are the initial segment of the reproductive system and extend medially from the ovary to the superior and lateral uterus. They're covered by peritoneum and surrounded by a portion of the broad ligament. The isthmus is found at the proximal end of the tube. This is the constricted region that connects to the uterus. The ampulla is the expanded lateral end that connects the tube to the infundibulum, a funnel-shaped opening at the distal end of the uterine tube, fringed with finger-like projections called fimbriae. Ovulation is the process of an immature gamete, known as an oocyte, being expelled from the ovary. The fimbriae sweep the ovary surface to catch the oocyte and direct it into the uterine tube. Smooth muscle contractions in the tube, along with the movement of the cilia that line the tube, work together to move the oocyte towards the uterus. Fertilization begins when a sperm cell binds to and penetrates the oocyte plasma membrane, and this generally occurs near the ampulla. The uterus is the pathway for sperm to enter the uterine tubes and provides a site for the newly fertilized ovum to implant itself, where it will be protected and nourished as it develops over the 9 months. It's a pear-shaped hollow organ in the pelvis anterior to the rectum, posterior to the urinary bladder. It's made up of three regions: the body, the main region, the upper fundus, and the narrow cervix, which connects to the vagina. The uterine wall has three layers. The outermost serous layer is the perimetrium, which is an extension of parietal peritoneum. The myometrium is the middle layer of smooth muscle, which contracts rhythmically during orgasm and childbirth, and the endometrium is the innermost layer that lines the lumen, made of simple columnar epithelia, which forms a mucous membrane resting on a thin layer of lamina propria. The ligaments provide structural support for the uterus. The lateral cervical ligaments extend from the cervix and superior vagina to the lateral pelvis. The uterosacral ligaments connect the uterus to the sacrum posteriorly, while the round ligaments connect the uterus to the anterior body, and the broad ligament supports the uterus laterally. The vagina is the organ of copulation, receiving the penis and semen during sexual intercourse, and serves as a passageway for birth and menstrual flow. It's a thick-walled tube extending from the cervix to the exterior of the body, runs parallel to the urethra, and lies between the urinary bladder and rectum. The vaginal fornix is the recess where the superior end of the vaginal canal surrounds the external os of the cervix. Os is just a term meaning opening. The vaginal wall is lined with transverse rugae, which stimulate the penis during intercourse. The vaginal mucosa is composed of stratified squamous epithelia Able to withstand friction, the mucus from the cervix provides lubrication. Epithelial cells make glycogen in the vaginal lumen, which is metabolized by bacteria, generating lactate that maintains the acidic pH in this region. The hymen is the vascular portion of the mucosa near the distal vaginal orifice that's often ruptured during intercourse, as well as other vigorous physical activity. The vulva is the external reproductive structure shown here. The mons pubis is the fatty rounded region overlying the pubic symphysis covered with hair after puberty. The labia majora is the pair of elongated fatty protective skin folds that lie posterior to the mons pubis, while the minora are the thinner skin folds found enclosed within the majora. The vestibule is the recess enclosed within the labia minora, containing the urethral orifice and vaginal orifice. Periurethral glands are found in the vestibule and discharge mucus into the urethra. The greater vestibular glands, also known as Bartholin's glands, secrete mucus into the vestibule during intercourse, while the clitoris is anterior to the vestibule. It's a small protrusion composed of erectile tissue, and when stimulated, the erectile tissue becomes engorged with blood. The tissue is innervated with sensory, motor, and autonomic fibers, as well as tactile, pressure, and temperature receptors, vital for sexual stimulation. The female perineum is a diamond-shaped region between the pubic arch anteriorly and the coccyx posteriorly, and the ischial tuberosities laterally. The perineal tissue overlies the pelvic outlet musculature. The posterior ends of the labia majora overlie the central tendon. The insertion of many muscles that support the pelvic floor are found here. Often, during birth, an episiotomy has to be performed. This is an incision made in the tissues of the perineum to prevent tearing during childbirth, which is extremely difficult to heal. We should point out that there are some comparisons between the male and female genitalia with regard to the adult structures and their common origins. We should point out that the greater vestibular glands, known as the Bartholin glands, are the female counterpart to the bulbourethral gland in the male. The labia majora, the counterpart to the scrotum, and the labia minora, the counterpart to the underside of the penis. The clitoris is the counterpart to the penis itself, and the periurethral glands are the counterpart to the male prostate. Mammary glands are modified sweat glands, components of the integumentary system whose primary biological role is to produce milk for the newborn. Each mammary gland is found within the hypodermis and enclosed within a rounded skin-covered breast, which is superficial to the pectoralis major muscle on the chest wall. The areola is a hyperpigmented region below the center of each breast surrounding the nipple through which the milk exits. Each mammary gland is made up of about 25 lobes that radiate around and open into the nipple. Each lobe is supported by fibrous connective tissue, fat, and suspensory ligaments that attach the breast to underlying muscle fascia and overlying dermis. Each lobe is subdivided into lobules containing alveoli that produce milk when the woman is lactating. Contraction of the myoepithelial cells that surround the alveoli helps to propel milk towards the nipple. The milk passes from the alveoli into a series of mammary ducts which flow into the lactiferous ducts that open into the nipple. Deep to the areola, each lactiferous duct has a dilated region called a lactiferous sinus where milk accumulates when nursing. The glandular structure of the breast is mostly undeveloped in women who are not pregnant. Now, because of the breast's proximity to axillary lymph nodes, we worry about breast cancer. It's very easy for metastatic tissue to move from breast tissue into the lymphatic system and from there use that as a transport mechanism to move throughout the body. So let's take a listen to breast cancer.
I was very terribly shocked to find out that I had breast cancer. In October, I went for my regular mammogram, and I found out that day that I had a spot on the mammogram from my regular doctor. And I was terribly shocked and went in for a biopsy the next day and found out that I had cancer. And they could not feel it, but as a matter of fact, it didn't show up in 3 out of the 4 mammograms that they took subsequently. But they saw it, and I had a biopsy and within 2 weeks, had a lumpectomy, and I waited for that to heal, and now I'm undergoing radiation for 6 weeks.
With regards to what surgery you wanted to have performed, in other words, doing a lumpectomy or doing a mastectomy, the choice really is yours, because the survival rate is identical for maintaining your breast with a lumpectomy or having your breast removed.
I go once a year for my mammograms, and this did not really show up before. I was in the practice of doing self-exams, but this one was very deep and very hard to feel, because the August, just before I had this mammogram, my own doctor couldn't find it. My greatest fear at the very first moment of hearing that I had cancer was, am I going to live? Am I going to die? But as I said before, the doctors were so positive about my recovery that I became that positive as well. My prognosis now, according to my oncologist, is in 20 years I have a 90% chance of being around.
Okay, our next topic is the physiology of the female reproductive system, and what we want to do is take a look at the process of oogenesis.
In human females, oogenesis, or egg formation, takes place within the ovaries. Each ovary contains diploid cells called oogonia, derived from embryonic germ cells. Before a woman's birth, the oogonia divide by mitosis. The result is more oogonia, some of which develop into primary oocytes. Primary oocytes are immature egg cells contained within masses of cells called follicles. The primary oocytes then enter meiosis I. This process stops uncompleted until puberty. No primary oocytes are formed after this point. At birth, each female has a finite number of primary oocytes available for reproduction. At puberty, a complex series of hormonal events stimulates changes in the surrounding follicle and induces some primary oocytes to complete their first meiotic division. The division of cytoplasm and cell organelles is unequal, however. As a result, one large secondary oocyte and one small polar body form per primary oocyte. The polar body often degenerates. The follicle containing the secondary oocyte continues to mature until a surge of the hormone LH initiates ovulation. The mature follicle ruptures, releasing the secondary oocyte. At this point, the secondary oocyte has entered meiosis II. This second meiotic division will not be completed, however, unless fertilization occurs. The secondary oocyte enters the oviduct, where fertilization of the oocyte with a sperm cell can occur. The entry of a sperm cell into the cytoplasm of the secondary oocyte triggers the completion of meiosis II. The cytoplasm divides unequally, generating a mature ovum and a second polar body. The fusion of the haploid sperm cell and the haploid egg cell has produced a diploid zygote.
The process of oogenesis is also outlined here. What you can see on the left-hand side of the chart are the developmental stages that the gametes go through from prior to birth all the way through puberty, and the corresponding developmental changes that take place in the follicle. Okay, so if we just follow the oogonia, these are diploid cells that mitotically divide, with the primary oocytes arresting in prophase 1, okay, at which point they are still considered to be diploid. Between childhood and puberty, these cells remain arrested in prophase 1 of meiosis 1, having already exchanged genetic material. And then, between puberty and menopause, every month, 1 of 24 primary oocytes will be selected for maturation under the influence of follicle-stimulating hormone. The first polar body will be shed at the end of meiosis 1, producing a secondary oocyte, which will not complete meiosis 2. It'll remain in metaphase until it is ovulated and then fertilized. Once ovulated and fertilized, it'll very quickly complete meiosis 2. Then fertilization will result in the introduction of the male pronucleus into the egg. The male and female pronuclei will fuse, and the result then will be the fertilized ovum or zygote, which is the first new cell of a unique human being. Okay, and you can see what happens to the follicle at the same time, right? The follicle is the egg chamber inside the ovary in which the egg sits, and as it matures, it gains more and more follicle cells, and fluid begins to fill the antrum. Ultimately, the fluid causes the antrum to become so fragile that the mid-cycle luteinizing and follicle-stimulating hormones surge, along with the mechanical action of the fimbriae over the top of the ovary, ultimately pop the single mature follicle that's generated each month in the average female, releasing the egg, producing ovulation, and then the remaining follicular cells form a temporary endocrine structure called the corpus luteum, and as we'll find out, its main task is to produce lots and lots of progesterone and to a lesser extent estrogen, and this helps to thicken the endometrial lining, preparing it for the arrival of the potentially fertilized egg. Let's take a look at spermatogenesis and oogenesis via comparison. And this is a look at the hormonal control of reproduction.
To understand the various ways that medical science can assist reproduction, it is important to understand how the reproductive system functions in both sexes, because the cause of infertility often lies equally with both men and women. The main players in the female reproductive cycle are the pituitary gland, the ovaries, and the uterus. Their activities are closely coordinated. Each month, one or other ovary releases a single egg, an event known as ovulation. It is brought about by a series of complex interactions between the pituitary gland, the ovaries, and the uterus. The pituitary gland is itself under the control of this small area of the brain known as the hypothalamus. A new menstrual cycle begins when the nerve cells of this center secrete a hormone called gonadotrophin-releasing hormone, GnRH, into the network of blood vessels which surrounds the pituitary gland. Stimulated by pulses of gonadotrophin-releasing hormone, cells in the pituitary gland secrete another hormone, follicle-stimulating hormone, or FSH. FSH travels in the bloodstream, reaching the ovaries. There it stimulates the formation and growth of an ovarian follicle in one or other ovary. The follicle consists of an egg, a number of surrounding cells which secrete estrogen hormones, and fluid. FSH helps the egg to mature and prepares it for release. As the follicle matures, the hypothalamus increases secretion of GnRH. This in turn stimulates the pituitary to secrete a second hormone which acts on the ovary. This is luteinizing hormone, or LH. Toward the middle of the cycle, there is a sudden peak in the blood level of LH. This acts as the trigger for ovulation. Within minutes of its release, the egg is guided by suction through the fringed opening of the outer end of the fallopian tube, starting it on a journey which will take 5 or 6 days as it passes down the tube and finally reaches the cavity of the uterus. Meanwhile, after the follicle ruptures, it is converted into this yellowish body known as the corpus luteum. Cells of the corpus luteum secrete the hormone progesterone, which brings about important changes in the lining of the uterus, preparing it for possible pregnancy. In fact, the lining of the uterus, known as the endometrium, undergoes changes in response to hormone levels during the cycle. In the first half of the cycle, known as the follicular phase, the developing follicle secretes increasing amounts of estrogen hormone, which encourages regeneration of the endometrium. After ovulation, there are important changes in the endometrium, aimed at making it suitable to receive a fertilized egg. These changes are brought about by a secretion of progesterone from the corpus luteum. The secretion of progesterone is maintained for several days, but if the egg is not fertilized in that time, the corpus luteum withers, and falling levels of progesterone and estrogen trigger the shedding of the uterine lining as the menstrual flow. The cycle then starts again. But if the egg is fertilized, no menstruation occurs, as the corpus luteum continues to function, secreting progesterone during the first 3 months of the pregnancy. Thereafter, numerous changes occur to support the developing embryo.
What you're seeing here is the series of events that lead to the maturation of the follicle and the ovulation of the egg in both diagrammatic and histological form. Note that estrogens and progesterone are involved in a multi-tiered negative feedback loop, including the hypothalamus, anterior pituitary, and the ovaries. The regulation of the female reproductive system is complex and requires rhythmic fluctuations of hormones. The oocyte develops inside the follicle, a blister-like structure in the ovarian cortex. Prior to birth, the primordial follicle are the first follicles formed in the fetus and they contain one primary oocyte. During childhood, most of the primordial follicles have died through a process called apoptosis, which is a form of programmed cell death. The remaining primordial follicles grow into primary follicles as the oocytes enlarge and develop into secondary follicles that contain arrested primary oocytes. They're arrested in prophase meiosis I. From puberty to menopause, one secondary follicle grows into a mature follicle or vesicular follicle once per month. This contains a secondary oocyte arrested in metaphase II. The vesicular follicle ruptures, resulting in the ovulation of a secondary oocyte. The ruptured follicle becomes a hormone-secreting structure known as the corpus luteum, which persists if the oocyte is fertilized or degrades into scar tissue if fertilization does not occur. The ovarian cycle includes monthly series of events associated with the maturation of an oocyte and its follicle in the ovary. The maturation of a single follicle and its oocyte takes many cycles, requiring up to 350 days to progress from primordial follicle to ovulation. The follicular phase occurs as the follicle grows and develops following the series of maturation events listed here in the diagram. The primordial follicle is a single layer of squamous follicular cells surrounding the primary oocyte during childhood. Many primordial follicles begin their development into primary follicles during this period. The primary follicle contains squamous follicular cells that have become cuboidal and are called granulosa cells. Microvilli and thecal cells appear in the primary follicle, forming a region called the zona pellucida that's vital once fertilization occurs. The secondary follicle exhibits a wall of follicular cells that thicken and deeper granulosa cells secreting fluid into the antrum. This increases the size and the volume of the follicle. The granulosa cells grow and stimulate cells in the ovary to form a layer of thecal cells around the follicle. In turn, granulosa cells produce estrogen from the thecal cell secretions. A vesicular follicle has small pockets of follicular fluid that merge into the antrum. The primary oocyte and its capsule of granulosa cells project into the antrum on a stalk. The follicle continues to enlarge, which creates a bulge on the ovarian surface. The primary oocyte suspended in prophase 1 completes meiosis 1 to form a secondary oocyte and the first polar body. The newly formed secondary oocyte arrests development in metaphase 2 and will only complete it if it is both ovulated and fertilized. In the ovulation phase, which is the event at the end of the follicular phase, the vesicular follicle erupts from the ovary wall into the peritoneal cavity, ejecting its secondary oocyte along with the granulosa cells known as the corona radiata. The vesicular follicle collapses and ruptured blood vessels bleed into the antrum, and the remaining follicle cells become the corpus luteum. This marks the luteal phase of development. The yellowish corpus luteum is formed by the remaining granulosa and thecal cells and secretes progesterone and some estrogen. This will persist for about 3 months and then degrade if pregnancy does not occur. The corpus albicans is a whitish knot of scar tissue that marks the end of one ovarian cycle. The remnants of a previously active corpus luteum are the corpus albicans after it ceases secreting hormones and is degraded by macrophages. Now we should point out, even in the event that there is a successful fertilization in pregnancy, the corpus luteum will eventually lose its role as the placenta takes over the production of estrogen and progesterone that helps to maintain the corpus luteum. So, bottom line, all the corpus lutea that form eventually become corpus albicans. The birth of fraternal twins is a phenomenon that occurs when more than one vesicular follicle releases a secondary oocyte. Identical twins result from the fertilization of a single oocyte by one sperm, followed by separation of the dividing cells during development. What's unique about these two situations is that in identical twins, the differences that are seen phenotypically, physiologically, biochemically, and physically are due exclusively to environmental effects, while in non-identical twins, fraternal twins, the differences are both genetic and environmental. The ovarian cycle averages 28 days, with each stage accounting for the following amount of time. The follicular phase runs from day 1 to 14, but this length may vary. The luteal phase runs from day 14 to 28 and is relatively constant. During the ovarian cycle, the regulation of these events requires rhythmic fluctuations of hormones from the hypothalamus, anterior pituitary, and ovaries that interact through a negative feedback loop. In males, the HPG axis is an example of the feedback loop core principle. Okay? One note is that ovulation is triggered by a positive feedback mechanism that exerts itself early on in the cycle. Estrogen and progesterone stimulate the development of the following female sex characteristics: maturation of the sex organs and development of the external genitalia, maintenance of anatomical features unique to adult females such as breast development and fat accumulation in the hips and thighs. Progesterone is responsible for the maintenance of a pregnancy once fertilization has occurred. Estrogens have effects on many other tissues, including increasing bone density and increasing beneficial HDL cholesterol levels. Estrogen promotes blood coagulation that can lead to the formation of blood clots in some circumstances. The hormones of the 28-day cycle are as follows. In first-tier control, the hypothalamus secretes gonadotropin-releasing hormone. Second-tier control involves the anterior pituitary releasing LH and FSH in response to this hormone. LH stimulates the thecal cells to secrete androgens. It targets granulosa cells. FSH stimulates the granulosa cells in the follicles to secrete estrogens and convert the androgens to estrogens and secrete inhibin. What are the effects? Well, the estrogens typically stimulate a solitary dominant follicle to continue developing into a vesicular follicle. The new vesicular follicle eventually produces enough estrogen to exert positive feedback on the anterior pituitary and to trigger a large increase in LH production known as the surge. The LH surge is accompanied by an increased FSH level, which triggers ovulation. The corpus luteum kicks out additional progesterone, estrogen, and inhibin. Increased levels of estrogen and inhibin exert negative feedback on the hypothalamus and pituitary. The estrogen inhibits the GnRH and LH secretion, while the inhibin inhibits FSH secretion, and this prevents any other primary follicles from beginning development too early. If they were to do so and they were to ovulate and be fertilized, they couldn't complete the pregnancy successfully, right? Because the initial implant would evacuate the uterus and the endometrium would be shed, and the second implant would be aborted as a result. In the event fertilization occurs, progesterone from the luteum inhibits the release of gonadotropins continuously for the duration of the pregnancy. In the absence of fertilization, the luteum degenerates into the albicans, estrogen, progesterone, and inhibin levels drop, GnRH levels begin to rise, and the cycle then repeats. The uterine or menstrual cycle is a series of cyclic events that the uterine endometrium undergoes through each month in response to changing levels of ovarian hormones. The uterine changes are coordinated with estrogen and progesterone levels released during the ovarian cycle, and they're under the control of gonadotropins released from the anterior pituitary. The endometrium is made of two main layers, the stratum functionalis, which is known as the functional layer, which undergoes cyclic changes in response to fluctuating hormone levels. The stratum functionalis detaches from the uterine wall and is shed as a discharge of about 50 milliliters of blood and other material from the vagina during menstruation. The thinner, deeper stratum basalis does not thicken in response to hormone fluctuations, nor is it shed during menstruation, but it replaces the stratum functionalis at the end of menstruation. It serves as the stem cell layer that generates the functional layer. Many endometrial glands change in length as endometrial thickness increases. The main uterine vascular supply comes from the uterine arteries, which are branches of the internal iliac and the pelvis. The uterine arteries terminate in the stratum functionalis as spiral arteries. The uterine cycle proceeds through 3 phases during an average of 28 days. The menstrual phase, which lasts from days 1 through 5, where the uterus sheds the functionalis, resulting in menstruation, and then the proliferative phase, from days 6 through 14, where a new functionalis is generated with endometrial glands, spiral arteries, and veins, which begins to thicken. These glands enlarge, and the veins and arteries increase in number. Ovulation occurs around day 14. Most of the change in the thickness in the endometrium during this phase is the result of cell division. The secretory phase runs from days 15 to 28. The spiral arteries convert the stratum functionalis into secretory mucosa, and endometrial glands secrete nutrients and glycogen-rich fluid into the uterine cavity in order to sustain the embryo. If the pregnancy doesn't occur, the cells of the stratum functionalis die, and on day 28 the menstrual cycle begins. If pregnancy occurs, the secretory phase continues, and the uterus continues to develop in preparation for the embryo. The regulation of uterine function requires rhythmic fluctuations of hormones from the HPG axis components. When the menstrual phase of the uterine cycle begins, FSH and LH start rising while the ovarian hormones are still low. By day 5, ovarian follicles increase estrogen production. During the proliferative phase of the cycle, estrogen levels rise and stimulate LH and FSH. This triggers ovulation. Ovulation generates a corpus luteum, which kicks out progesterone and estrogen. During the secretory phase of the cycle, rising progesterone levels and decreasing estrogen levels inhibit luteinizing hormone. If fertilization doesn't occur, progesterone levels decrease, the stratum functionalis breaks down, and the menstruation phase begins. If the fertilization does happen, the outer layer of the developing embryo begins to secrete human chorionic gonadotropin, which maintains the corpus luteum from degenerating, and progesterone levels remain elevated through the first 1.5 trimesters of the pregnancy. Sexual response is similar in females to what we see in males. During sexual excitement, the vaginal mucosa, vestibule, and breasts are engorged with blood. The clitoris and nipples become erect, and increased activity of the vaginal mucosa and vestibular glands lubricates the vestibule. Tactile and physical and psychological stimuli are mediated by autonomic pathways and promote excitement. Orgasm refers to the period during which women experience intense feeling of pleasure without ejaculation. The uterus experiences peristaltic waves of contraction and the cervix pushes into the vagina. These activities may draw semen further into the reproductive tract. Unlike males, there's no refractory period and conception is not dependent on orgasm. Female libido may be related to androgen dehydroepiandrosterone, DHEA, which is generated by the adrenal cortex. Androgens and estrogens influence sexual behavior because of interactions with the hypothalamus. Many women experience fluctuations in libido in response to monthly fluctuations of estrogen and progesterone. For most girls, puberty begins between 9 and 11 years of age, when the secretion of estrogens and progesterone increases from the ovary. Prior to puberty, low GnRH levels keep LH and FSH levels low, and this reduces estrogen and progesterone levels as well. At puberty, the hypothalamus gets less sensitive to low levels of estrogen and progesterone, and gonadotropin levels go up. These high levels stimulate the HPG axis, and blood levels of estrogen and progesterone increase. This results in the development of female secondary sex characteristics. The first sign of puberty in girls is an increase in the size of the breast, followed by other secondary sex characteristics such as the appearance of pubic and axillary hair and an increase in secretions from sebaceous glands. Adipose tissue increases in subcutaneous layers throughout the body, with additional deposits in the hips, the thighs, and the breasts. The individual's height increases and the hips widen. Menarche will occur at some point. This is the first episode of menstrual bleeding and occurs about 2 years after the onset of puberty. It won't occur unless a girl has at least 17% body fat. Leptin, a hormone made by adipocytes, stimulates gonadotropin secretion, and if leptin levels drop due to low body fat percentage, gonadotropin levels will drop, and this affects the HPG function. After puberty, reproductive cycles continue at a regular interval until the 4th or 5th decade, when they become irregular. The female climacteric is the period from the onset of irregular menstrual cycles until their cessation. It varies, but it can last as long as 5 years in some women. Menopause is the point when menstruation has not occurred for at least 1 year. The number of primary follicles left that can respond to LH and FSH is diminished after 30 or more years of ovarian cycles. Atresia is the process in which immature follicles degenerate and are reabsorbed during the follicular phase of the menstrual cycle. The remaining follicles are less responsive to gonadotropins, so less estrogen and progesterone are produced. Ovulation doesn't occur, and estrogen blood levels drop significantly, while LH and FSH continue to be secreted as the pituitary is no longer inhibited. Reduced levels of estrogen and progesterone may alter female secondary sex characteristics. The breasts, uterus, and uterine tubes may shrink, while pubic and axillary hair may thin. Bone density may decrease, and this increases the risk of developing osteoporosis. Vasomotor signs that include hot flashes may occur due to changes in rhythmic secretions of gonadotropin-releasing hormone by the hypothalamus in response to decreasing blood levels of sex hormones. Women may experience other nonspecific symptoms, including migraines, backaches, fatigue, and mood swings. Early menopause is the occurrence of menopause before the age of 45, while premature menopause occurs before the age of 40. In your book, Table 26.3 provides a summary of functions of the major reproductive hormones for both males and females. Our next topic is birth control, so let's take a listen. Okay, STDs, or STIs, are a group of infections caused by a number of different bacteria, viruses, and parasites spread through sexual contact. It's the most common cause of reproductive disorders. It's often the cause of infertility in adults and deformity, and possibly the death of the fetus. Bacterial and parasitic STIs are caused by pathogens such as bacteria and parasites that invade tissue and cause inflammation. Chlamydia is caused by bacteria. Chlamydia trachomatis is typically asymptomatic. Symptoms, if present, include painful urination, pain in the pelvic region, testes, and vaginal or penile discharge. Newborns may become infected in the birth canal, and this can result in respiratory tract infections and a form of conjunctivitis that can lead to blindness. Left untreated in women, chlamydia can spread to the uterus and the uterine tubes and cause PID, leading to infertility. Gonorrhea is caused by the bacterium Escherichia gonorrhoeae. If symptoms occur, they include painful urination and penile discharge. Women are typically asymptomatic, but may experience painful urination and vaginal bleeding. If left untreated in women, gonorrhea can lead to PID and blindness in newborns. Syphilis is caused by Treponema pallidum, which causes small painless lesions known as chancres up to 6 weeks after exposure. At this point, the disease is transmissible to others who come into contact with the sore. Secondary syphilis develops after the chancre heals, causes a pink rash all over the body. Fever and joint pain are common here. If untreated, the disease enters a latent stage where symptoms subside. These can come and go for years. The immune system eventually kills the bacteria or may progress to tertiary syphilis, which produces destructive brain lesions and damages cardiovascular organs, bones, joints, and may be fatal. Trichomoniasis is caused by the protozoan Trichomonas vaginalis. It may cause itching, burning, or redness of the genitals. In women, it may result in white to greenish vaginal discharge and a strong odor. The disease is asymptomatic in many individuals. Infection during pregnancy can lead to premature birth and low birth weight. Viral infections are caused by small non-living viruses that take over cellular organelles responsible for protein synthesis, generating new copies of themselves that can be released to or infect new cells. Genital warts caused by HPV are one of the most common STIs in the U.S. Warts appear on the penis, perineum, or anus in males, and on the cervix, vaginal wall of the perineum, or the anus in females. Recurrent respiratory papillomatosis is a rare condition that leads to warts in newborns' throats when the mother has genital warts late in pregnancy. Several strains of HPV increase the risk of developing cervical cancer in women. And we should talk about that for a minute. Why is it that viruses are associated with cancer? And the reason is that they integrate their DNA into our DNA, and this can cause the dysregulation of genes that control cell cycle, leading in some cases to cancer. Genital herpes is caused by herpes simplex type 2. Many individuals infected with herpes are asymptomatic, while individuals of both genders suffer with extremely painful blisters on the external genitalia, thighs, and buttocks. The disease is transmissible when these blisters are present, as the virus is shedding if there is direct skin-to-skin contact. Spreading infection is still a risk even during the dormant stage, or time period between blister outbreaks, which can last from weeks to years. Herpes can be passed on to newborns, causing neonatal herpes, which can be fatal. Genital herpes can increase the risk for contracting HIV and some types of cancer. Cervical cancer occurs most often in women between the ages of 30 and 50, particularly those with a history of sexually transmitted infections, cervical inflammation, or multiple pregnancy. It's frequently caused by HPV, which is transmitted sexually. Cervical cancer used to be the leading cause of cancer death for women in the U.S. in the past few decades. Both the number of cases and the number of deaths from cervical cancer have decreased significantly. It's projected to decrease further as HPV vaccines become more widespread. The decline is due in large part to Pap smear tests, which detect precancerous cells at early stages before symptoms are noticeable. This involves scraping loose cells from the external os of the cervix and examining them under a microscope. Cells showing signs of abnormal development warrant further investigation, including visual examination of the cervix or a biopsy to determine if cancer cells are present. If cancerous cells are detected, surgical removal of a tumor or even a hysterectomy, which is the removal of the uterus and in some cases all the reproductive organs, may be required. In addition, radiation or chemotherapy may be used. Okay, that brings us to the end of the chapter on reproduction. Remember to review this material as it will be covered on the exams and on the PRS quizzes. And I'll see everybody in the final podcast. Thank you for listening.